Start recording. Let's share our screen. And let's get this party started. All right, so let's see here. UTA class, you guys take your exam on Sunday. UT Dallas class, you guys take your exam on Monday, okay? So we're going to Module 1. And I'm going to pull up that exam 1 review, and that's what we're going to go over, okay? Plus a couple other things that I want to make sure you guys are good with. So this is what we're doing. Okay, and can everybody hear me okay? Yeah, heads up or a thumbs up or a... Perfect, excellent. We got a lot of people on. This is exciting. I'm super excited that we've got people. Okay, sweet, excellent. Let's do this. All right, so first off, your Module 1 is going to be over anatomy, physiology, BLS, patient assessment, shock, airway management, basically all the things that we've done so far, right? There's not going to be any skills testing or anything like that, but the skills that we have learned so far are supposed to help you with the understanding of the knowledge. The skills testing, again, will be done at the end of the course. So let's just jump right in. This exam 1 review is not everything that you should know. I just if you've been reading your chapters and doing your emergency charts, then you should be good. But this is, I guess, it's not everything, but I do go pretty in depth. Okay. So this first question is a fill in the blank, and we will not have fill in the blank on the test. Okay. The test is going to have multiple choice, multiple answers, drop down boxes, things like that. There is never going to be an open field where you have to type in your answers. Okay. So please understand that that's not the case. Just making a note. Hang on. There we go. All right. So this first question deals with anatomy and physiology, and it's really important to be able to understand and just follow that drop of blood, right? Follow the drop of blood through the heart, through the body, through the heart, how it travels, and what's just the normal travel of direction of blood. So we have the blood returns from the upper body to the heart via the superior vena cava, right? The vena cava is the main vein that brings blood back to the heart. And when we're coming from the upper body, it's called the superior vena cava. When we're coming from the lower body, so B, when blood returns from the lower body to the heart, that is the inferior vena cava, okay? So if you can picture where your heart is, you've got, just a moment, because someone's saying they can't get on. Okay. So if you picture the heart, everything from like your upper extremities and your neck and your head, that would be considered your upper body. So that's what feeds into your superior vena cava. And then everything from your lower thoracic, your abdomen, your legs, your lower extremities, all of that is your lower body. And that comes back to the heart from the inferior vena cava. Okay. So, and when it gets to the heart, it enters the right atrium. So C would be the right atrium. It's going to travel. It's going to, the right atrium is going to contract, and it pumps through the tricuspid valve into the right ventricle. So D is right ventricle. Okay. And then you have Starling's law, pushes deoxygenated blood through to the what? And real quick, Starling's law is basically if you take a rubber band, and if you stretch that rubber band, like 2 inches in one direction, then it's going to come back 2 inches in the opposite direction. Okay. And Starling's law is pretty much that concept of the heart. If you fill it with a certain amount of blood, then it's going to contract that amount of blood, right? So the amount of fill equals the amount of contraction. So the contraction, or Starling's law, is going to push that deoxygenated blood from the right ventricle to the lungs via the pulmonary artery, okay? In the lungs, blood is oxygenated in the lungs, and it's sent back to the heart from the pulmonary vein. Oxygenated blood then fills the heart, entering what part? And that's the left atrium. And the left atrium contracts, and it gets sent through the bicuspid valve into the left ventricle. And you'll hear me say this quite a bit. The left ventricle is the powerhouse of the heart, because the left ventricle is what pumps blood to our body, right? So it is then forced out into the aorta, out to the body, right? So the left ventricle contracts, and it travels out through the aorta. So the aorta is the main artery that takes blood away from the heart to the body. And then, when we were looking at A and B, the vena cava is the main vein that brings blood back to the heart. Okay. So it's forced out through the aorta out to the body. And then, but first we have fresh oxygenated blood is sent to the coronary arteries to supply the heart muscle. All right. So knowing your A and P, knowing how that blood travels through is really important. I think one of the things that makes it kind of easy to think about is we always think of arteries carry our oxygenated blood, whereas veins carry the deoxygenated blood. So like when you're looking in your book, or if you're ever looking at a picture of the circulation, the human body and the circulation, you're going to have some blood vessels that are red and some blood vessels that are blue. And that normally depicts, the red is normally your arteries because it has that oxygenated blood, right? It's already gone through the lungs, picked up the oxygen molecules, and it's this oxygen rich blood, versus your veins are deoxygenated, right? After the blood drops off the oxygen into your cells, and it picks up carbon dioxide, and as it's traveling back, now it's deoxygenated blood and always travels back to the heart with your veins. So that's one way to think about it, which works for every single blood vessel in your body except one very important one, and that is what we went over in E, okay? So if I said that every artery is oxygen rich, that's not true because of this one main artery, and that's your pulmonary artery, okay? Because your pulmonary artery comes off your right ventricle, and it pumps, and it's deoxygenated right now because the pulmonary artery is what takes it to the lungs in order to get oxygen, and then the pulmonary veins come back, right? So in the lungs, it's opposite. In the body, the arteries are oxygenated and the veins are deoxygenated, but in the lungs, it's opposite. So another way to remember would be arteries take blood away from the heart, whereas veins bring blood back to the heart. Okay. As long as you understand that your respiratory, your lungs, those two are swapped as far as, what carries the oxygen and what doesn't, then you'll be able to understand that and not get those mixed up. All right, so this second question is just a really quick thing about just making sure you're good with the following terms. And this deals with your medical terminology, right? So when you're looking at this word, you have P-N-E-A, that's your root word, and that means breathing or to breathe. And this first part, dis, that's your prefix, and that means difficulty. So dyspnea is difficulty breathing, right? Apnea, when you look at A as your prefix, apnea is without. So apnea is your patient is not breathing at all. Tachypnea, tachy means fast. So this is fast breathing. Brady or bradypnea, this is slow breathing, right? And we learned what hyper and hypo was. So hyper is always, above or above the normal or excessive. And hypo is lower, below the normal or less than normal. So hypoxia is going to be your decreased oxygen in the tissues. And then don't forget those agonal respirations that we learned on CPR, on our second day of class. Agonal respirations, those are the slow, shallow, very infrequent kind of gaspy breaths that indicate cardiac arrest. Okay, they're already in cardiac arrest, or they're literally about to be in it. Okay, so agonal respirations indicate cardiac arrest. This third one deals with the concepts and everything that we kind of went over in our last class, where we're talking about respiratory distress versus respiratory failure. So I'm going to get into this a little bit and just kind of review a little bit of that. So remember, respiratory distress is where your patient is working harder to breathe, but despite that, they're still getting enough oxygen to their cells, right? So your respiratory distress patient is not hypoxic, right? They're not hypoxic. They're okay as far as oxygen levels are. They may be struggling. They may have that increased work of breathing, but they're still getting enough oxygen. And so the three signs that you're going to see is your normal mental status, or your mental status is going to be normal, right? Because the brain has enough oxygen to function normally. The skin is going to be normal in color or not cyanotic. They might be pale. They might be a little off by that, but they are not cyanotic. And then the mechanics of their breathing or their ventilations, their rate, their respiratory rate, and their tidal volume are both adequate, right? So when we have all of that, then we're only in respiratory distress. You may have increased work of breathing, right? Remember, you might have some abnormal lung sounds. They might be wheezing. They might have stridor. They might have any of that kind of stuff. They may be using accessory muscle uses in order to help them breathe. But despite that, they're still able to get oxygen into their body, oxygen to all the vital organs, like their brain and their heart and their other tissues, and they're still good, right? So respiratory distress has a normal mental status, skin that is not cyanotic, and has a normal or regular respiratory rate and tidal volume, okay? Now, respiratory failure is when whatever problem that your patient was having or is experiencing as far as breathing difficulty, that problem has persisted, and now they're really in trouble. Okay, because now they are not breathing adequately. So because of that, your patient is going to have altered mental status, right? Their mental status is not going to be normal anymore because they don't have enough oxygen for their brain. So they'll be altered. Their skin will be cyanotic. And then you're going to see that insufficient respiratory rate and or tidal volume. Okay. Another piece of this, which is really just to understand, is your patient will be they're going to have low oxygen sats even if they're on that high flow oxygen. Okay, so if I'm using a non-rebreather to deliver oxygen to them, but they're in respiratory failure, then their oxygen sats from the pulse ox is going to be low, right? Because even though I'm giving them oxygen, they're not able to bring it into their body. Okay, and then respiratory arrest is kind of like the last one before we get to cardiac arrest. Respiratory arrest means they are not breathing at all. So this is where you're going to see apnea or your agonal breathing. Okay. And then again, I mean, super simple. Your patient absolutely will be cyanotic at this point, right? Because it's worse than failure. So they're absolutely cyanotic. They're going to have low O2 sats. You may not even be able to get oxygen sats because it's so low. And their respiratory rate is absent, so 0. And they have no tidal volume, right? No chest wall, no chest rise and fall, no tidal volume, because arrest, or A, means without, right? So the progression of this is we have shortness of breath, and your patient starts in respiratory distress. If that doesn't, if we don't fix it during that time, then they will progress to respiratory failure, where they're not breathing adequately, and then I have to breathe for them, right? We have to assist their ventilations. If that doesn't, if it doesn't get fixed here, then they're going to stop breathing altogether, right? Just altogether, they're going to be in respiratory arrest, which is not breathing at all. They still have pulses, but they are not breathing. And then if you wanted to put like D down here for a fourth phase, that's going to be your cardiac arrest. And that's going to be when they are no longer breathing and now have lost their pulse, right? So that's why it's so important to recognize what phase your patient is in and what is the appropriate treatment of taking care of the patient in that phase so they don't progress to the next one and they don't get worse. Okay. So knowing the difference, I think sometimes, especially in the beginning of class or the beginning of the course, people have a tendency to get respiratory arrest and cardiac arrest mixed up. Respiratory arrest is they're not breathing, but they do have pulses, and cardiac arrest is they are not breathing and they do not have pulses. So just make sure that you're good with that and you understand that. Okay. Number 4, this is pretty much a lot of what we just talked about, but I'll do it again because it's if you hear it in different ways, then sometimes it gets into the brain a little bit easier, right? So number 4, let's explain the difference between adequate and inadequate breathing. What are some signs and symptoms of each, right? And then how do we treat them? So adequate breathing, it's adequate, so the rate is good. And if you have an adult patient, your rate is going to be between 12 and 20. And if it's good, if it's in there or in between 12 and 20, then you're good. And the volume itself is good. Remember, so your tidal volume is the amount that you bring in per breath. And if your respiratory rate is good and your tidal volume is good, then you have adequate breathing. Okay, and that adequate breathing is oxygenating the brain and the body, and providing the oxygen to all the vital organs. So the signs and symptoms, you're going to have good tidal volume, good chest rise and fall, pink skin, normal respiratory rate, your mental status will be normal, and your pulse ox will be good, right? You'll probably have a pulse ox higher than 94%. How do I treat that? I'm going to treat it with supplemental oxygen. I can give it through nasal cannula, non-rebreather, nebulizer. If they need the medication that comes with the nebulizer, I might need to use a CPAP. Okay, but the breathing is still adequate, so I don't need to bag them yet, right? I don't need to assist ventilations because the rate and the volume is adequate. So the treatment is only oxygen, or some of those respiratory medications, which we'll get into in Mod 2. Okay, I don't expect you guys to know that yet. Now, your inadequate breathing, which is what we see in respiratory failure, is when that respiratory rate is inadequate, so it's less than 12, and or the tidal volume is diminished and inadequate, right? So that's going to result in hypoxemia, which is going to lead to your hypoxia and your altered mental status. So the signs and symptoms, cyanosis, altered mental status, and their pulse ox is going to be less than 90% even when they're already on oxygen, okay? Even when they're already on supplemental oxygen. And the treatment, the only treatment for inadequate breathing, which we would see in respiratory failure, the only treatment is to use the BVM, right? Is to assist ventilations with the bag valve mask device. We also call that providing positive pressure ventilations. Okay, so just make sure that you remember that when I'm using a BVM, I'm assisting ventilations and providing positive pressure ventilations. That's the only way to do it. Now, I do have a question, and I know I asked this question probably in all of our classes, but right now, as we're sitting here and I'm talking to you guys on this review and you guys are listening to this review, you guys are breathing the air around you, right? You're breathing the just the normal atmospheric air. And right now, you're only receiving 21% oxygen because that's the only, we only have 21% oxygen in the air around us, okay? So if you were bagging a patient and you did not have that BVM hooked up to oxygen, hooked up to an oxygen tank with it turned on, then you're bagging only 21% oxygen into them, okay? You're bagging room air into them. If you did have the BVM hooked up to your oxygen, and remember, don't forget about your different liters per minute, right? Your BVM is 15 and above. But if I had it hooked up and it was cranked up and I'm delivering supplemental oxygen to my patient, then I'm giving them 100%, right? So just make sure you know the difference between your room air, which is 21%, and then when we talk about doing supplemental oxygen, that means we have them hooked up to the tank and we're giving them, 100%. Okay. So we're going to switch gears now and talk a little bit more about A and P before we move on to our next one. Oh, excuse me. This next question, number 5, is talking about the nervous system and how the different systems function, what they are, and kind of how it works. Okay. So before we get into just these 3, which I always go over more because just these 3 is not everything, right? You kind of have to understand a little bit about the whole nervous system here. So I want you to think about your central nervous system and your peripheral nervous system. These are kind of the starting place, okay? Your central nervous system is the brain and the spinal cord. Super simple. Central nervous system, that's your brain, right? That's the computer of the body. Just think of it that way, right? The central hub, the central nervous system is the brain and the spinal cord. Now, the peripheral nervous system are the nerves outside of the brain and spinal cord that link the central nervous system to the other parts of the body, right? So if we were to see central nervous system versus peripheral, if we were to just kind of look up some pictures here, then you're going to see your central nervous system, which is the brain and the spinal cord. And the spinal cord, remember, goes all the way down inside that vertebral column, right? And then your peripheral nervous system is going to be all of the nerves that come off of that spinal cord and innervate the different organs and different parts of our body, right? So making sure you know the difference between those two, that's important, okay? And then hang on, let me pull this back up here. So if we go back to our review, and you're looking at this, now let's talk about the autonomic, okay? So your autonomic nervous system is a part of the peripheral nervous system, okay? So the autonomic is the part of the peripheral system that controls the automatic functions of the body, such as sweating, digestion, dilation and constriction of the blood vessels, and things like that, okay? Your the other half of your peripheral system is called the somatic nervous system, okay? So earlier we talked about the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which is all the nerves that are outside of that and coming off the spinal cord, right? Then you've got your peripheral nervous system that breaks into 2 separate pieces. Here's your autonomic, the one we talked about just a moment ago that has the involuntary functions, right? These are the things we don't have to think about. It just happens. Versus your somatic nervous system, which we do think about. It's the voluntary actions, okay? So just kind of think about how that breaks down into 2. And then I want you to take your autonomic, and this is going to branch into also 2 different sections into what we call that sympathetic nervous system and the parasympathetic nervous system, all right? And this is definitely important to know. So your parasympathetic versus your sympathetic, think about the last time that something scared you or startled you, right? And you broke out into that cold sweat and your heart was just pounding, you know? That's your that's your sympathetic nervous system, right? That's what we call our fight or flight. And this guy which is a part of our autonomic, which means it automatically happens. I didn't make it happen. It was an automatic response, right? So the sympathetic nervous system, this is what we call our fight or flight. And remember this because this is getting me ready to either fight for my survival or flee, right? Fight or flight. So fight for my survival, or flee or run away in order to survive, right? So this is what's going to get me kind of keyed up when you're talking about your heart rate's going to increase. Okay, it's going to increase the heart rate. It's going to dilate my bronchioles so I can breathe in more air and get more oxygen into my system quicker. So I can either fight for my life or run away for my life. Okay. It's going to dilate my pupils so I can see better, so I can take in more light and I can see better for survival, right? And what this does is it inhibits pretty much all of my digestion things. It's going to make sure I'm not going to be drooling. I'm not going to be producing a whole lot of saliva. My digestion and stuff like that is not really going to be working, overtime, because all of my energy and all of my things that I need to actually be happening right now with this sympathetic nervous system, this fight or flight, is I need to have increased blood flow and increased oxygen to my big muscles so I can either fight for survival or run away, right? This is also going to cause vasoconstriction. Okay, so it's going to constrict my my peripheral blood vessels. And when I say that, so constrict means makes them smaller, right? It's going to constrict my peripheral blood vessels and make sure that my big muscles are being fed the most blood and oxygen. So that's why when we say that you break out into that cold sweat, it's because on the surface of your skin, my peripheral or capillary, if you want to think of it that way, the blood vessels that are close to the surface of my skin have vasoconstricted. Okay, so I'm not hot, I'm more cool. The diaphoresis, or the sweating, is to help keep me cool while I fight or run, right? So that's why I'm at that cold sweat. And let's see what else. So pupils dilate, heart rate increases, bronchioles will dilate so I can get more oxygen in. Got that cool, clammy skin. I'm just getting ready to take on something that I have to survive. Versus my parasympathetic nervous system, which is kind of the thing that slows me down. Okay, this is the other side of the coin. It slows me down. This is what I like to call our rest and digest, or feed and breed. Okay, so sympathetic nervous system is fight or flight. Parasympathetic is rest and digest, or feed and breed. And if you notice, it's pretty much the opposite of what we just talked about. This guy, my heart rate's going to slow down. Okay. My bronchioles are going to constrict a little bit, not to the point of me having a problem, but over here, my bronchioles dilate because I need to bring in more oxygen for what I'm trying to do. Over here, when I'm digesting my food and I'm just kind of hanging out and resting, I don't have to have large amounts of oxygen come into my body, right? So my bronchioles are just going to be kind of normal. My pupils will not have to dilate. My pupils will be a little smaller because I don't need to bring in all this light and all this vision in order to survive while I'm just eating and at rest, okay? But if you notice, saliva production will increase, digestive organs and all that kind of stuff will be stimulated, right? So you'll see how it's literally the opposite of that. So just making sure that you understand how the nervous system works, the different sides of the nervous system, what's part of what, and how we respond to certain things. Now, can you be at rest and sitting around chewing on your crackers or whatever, and all of a sudden something scares you and bam, you're over here on this sympathetic nervous system and your heart is beating so hard that it feels like it's about to jump out of your chest? Absolutely. And that cold sweat hits you, and it takes a couple of minutes to calm down if there isn't a threat, right? So the hormone that is stimulated and released with this sympathetic nervous system is epinephrine. Okay, that's the hormone that we actually release into our body, that our body releases when that sympathetic nervous system is stimulated. Okay, which is also really important to understand, because when we talk about epinephrine as one of the medications that we can give when we go into Mod 2, if you understand how that sympathetic nervous system, how it works with the increased heart rate, dilate the bronchioles, causes vasoconstriction. If you understand that, and you understand that this is all from that epinephrine, then you'll understand how epinephrine works when we give it to our patients. Okay, so those are important. A little bit more A and P. Number 6, what are the following receptors? What do they measure? Where are they located? What do they do? So you have your baroreceptors and your chemoreceptors. Baroreceptors are pressure sensors. Okay, they're special pressure sensors located throughout the body. It allows the brain to receive information about the blood pressure, right? And you guys learned how to take blood pressures last class, right? So this is how the brain is going to receive information about the different pressures within our blood vessels, okay? The main locations of these baroreceptors are going to be in the aortic arch and your carotid arteries. So let me see if I can pull this up here. Baroreceptors. If I can spell. Okay. So your baroreceptors are going to be mostly in, here's the heart, right? You see how we've got the, the blue and the red? So the blue, that's my vena cava. The red, this is my aorta. And you see how big it is. This is the aortic arch, okay, where it turns and it heads down the body. These are my carotid arteries that come off the aorta and go straight up to my brain. I've got one on the right, one on the left. That's where we feel our pulse points, right? In the carotid arteries in the neck. This is where one of those baroreceptors is. And it's like a direct line to the medulla oblongata. And we'll talk about that in just a moment, how important that is. But it's going to, the baroreceptors, when it's given this information about blood vessels and blood pressure, to the brain, that's going to help the brain decide on whether or not we need to vasoconstrict, vasodilate, like what do we need to do? Because all of your blood vessels are surrounded by smooth muscle. And that smooth muscle is acted upon by the autonomic nervous system, or the ones that we don't have to think about, the involuntary actions, and it's going to constrict and dilate your blood vessels as needed in order to maintain good blood flow and do what we need to do, right? But the main location of your baroreceptors is in this aortic arch and in your carotid arteries, okay? So it's going to keep your blood pressure balanced. It's going to, these are your blood vessels, right? And the lumen, or the opening, this is vasodilated, and this is vasoconstricted, right? Because the opening is a lot smaller, and the muscles have constricted down in, right? So baroreceptors is all about pressure, blood pressure, information about the blood pressure. Does your body need to, or does your brain need to send the signal to vasoconstrict or vasodilate to adjust your blood pressure as needed? Chemoreceptors, on the other hand, are going to monitor the levels of oxygen, carbon dioxide specifically, that's the big one. It'll also monitor levels of hydrogen ion concentration and the pH of your cerebrospinal fluid, okay? And the cerebrospinal fluid is the fluid that's in your head, in your cranium, that your brain is floating in, right? because your brain's inside your cranium. That's the fluid that it's in, and it's also fluid that runs along the down your spinal cord. Okay, so cerebral spinal fluid is going to have the pH values of the CSF, or cerebral spinal fluid, will adjust and change based upon the amount of oxygen and carbon dioxide that we have in the body. Okay, and these chemoreceptors are going to provide feedback to our respiratory centers that will help to part of our autonomic nervous system, that are going to help to modify the rate and depth of breathing based upon what our body needs. Okay. Again, breathing, we don't have to think about it, right? That's an involuntary action. That's part of the autonomic nervous system. I don't have to think about breathing. And your body is going to maintain a good balance. If you have too much carbon dioxide in your body, then we're going to start to breathe faster. It's going to balance it out. Let me pull up a picture here. See if I can get you a good picture. Okay. Yeah, maybe this will work. I don't know. Let's see. Okay. Oops. This is what I want right here. So here's your brain. Okay. And this right here is your, that's your cerebellum, right? This is your cerebrum. This is your cerebellum. This is your brainstem. Your brainstem is the most primitive part of your brain, and it's the most protected. Okay, part of your brainstem is the pons and the medulla oblongata. The medulla oblongata, which we heard with those baroreceptors, that's a very important piece. Okay, so central chemoreceptors are going to be in the medulla oblongata within that brainstem. You're going to have some peripheral chemoreceptors in the carotid arteries, that aortic arch, right? The aortic arch that the baroreceptors was in, the carotid arteries that the baroreceptors were in. It's going to be in some different places. And what's going on with this stuff is it's looking for the levels of basically chemicals in your body, okay? The chemical composition of the blood with your oxygen, your carbon dioxide, and that kind of stuff. The buildup of CO2, and CO2 is carbon dioxide, and remember, carbon dioxide is a waste product of cellular metabolism in the body, okay? So when we utilize oxygen, okay, so that aerobic metabolism, when we utilize oxygen, our waste product, one of our main waste products, is CO2, all right? And carbon dioxide will be brought back to the lungs so we can breathe it out. But if there is a buildup of carbon dioxide within the body, then that will cause a drop in the pH levels of your cerebrospinal fluid, or your CSF, and that, that chemoreceptor in your medulla oblongata is going to notice that, okay? Because the cerebrospinal fluid is all around the brain, right? So that chemoreceptor is going to pick up on the change. Your medulla oblongata at that point is going to say, all right, we need to do something, okay? We have too much carbon dioxide in our body, so we need to change something. And that means I'm going to adjust my respiratory rate. So it will stimulate that phrenic nerve, okay? And the phrenic nerve is the main nerve that innervates your diaphragm. So it's going to stimulate that phrenic nerve, and it sends a signal down to the diaphragm to increase the activity of that muscle. So it's going to increase the respiratory rate and increase the tidal volume based upon high levels of carbon dioxide in the body, okay? So it's very interesting when you think about it. If you guys thought that we breathe because we need oxygen, that's actually not the case. We breathe because we need to get rid of carbon dioxide, okay? So that's the key piece that I want you to understand from that. The act of breathing actually occurs because of the buildup of CO2. It's not the need for oxygen, it's the buildup of CO2. And that medulla oblongata is the main piece of this, okay? The medulla oblongata is the main piece for those involuntary actions such as breathing and things like that, okay? We breathe to lower the levels of carbon dioxide in our body, not to increase the levels of oxygen, okay? So, and all of this stuff is happening right now while you guys are listening to this review and while you guys are, looking at all this stuff. Your baroreceptors and your chemoreceptors, they're constantly sending information to the brain to make sure that everything is good in your body, right? Okay. So, let's talk about what's considered normal and what's considered abnormal, right? So, excuse me. Last class, when we were obtaining vital signs and learning all that stuff, it's really important to understand what is quote unquote normal, right? Or textbook, if you will. So the normal heart rate of an adult is, there's a range. It's between 60 and 100. That's the normal heart rate for an adult. For a pediatric, it's going to be faster, right? Pediatric is going to have a normal heart rate that is faster than that of an adult. So it could be up to 140 beats per minute. If they're even younger, maybe a toddler is going to have a heart rate that goes up to 190, and that's still normal for them. And you could have infants that go all the way up to, 205, things like that, right? About 200 beats a minute. So understanding the normal ranges for your vital signs is really important. And the best place to find this is if you go into your book and you go to chapter 10. For your heart rate, you have there's a table in chapter 10. It's table 10-6. So 10-6 is for your normal ranges of heart rate for your different age levels of your patients. Your respiratory rate is also extremely important to know, right? If you are, when you're taking an exam, whether it's National Registry or ours, hopefully it's always going to give you the age of your patient. But if it doesn't, then it's safe to assume that this is an adult patient, okay? But most everything, I'm pretty sure, like 100% of all of our questions, if I am asking you about a specific patient, it has the age of the patient. So right off the bat, am I looking at an adult? Am I looking at a pediatric? Who am I looking at? And what is, and you should be thinking in your head, what is considered normal, right? So the respiratory rate, remember the normal respiratory rate for an adult is 12 to 20 breaths per minute, okay? For a pediatric patient, they breathe faster. Okay, that's normal for them. They inherently breathe faster than adults do. So 20 to 30 beats per minute. Your toddlers may be up to about 40 beats per minute, and your infants can go all the way up to 60. They could be 30 to 60 breaths per minute, right? So again, taking a look at your chapter 10, I think your chapter 10 is your lifespan development chapter. The chapter 10, if you look at table 10-4, for your respiratory rates, that'll tell you what's normal for them, for your respiratory rates, for your different age groups. Blood pressure is the same. It's going to be different. But the thing about blood pressure, heart rate and respiratory rate, the normal pediatric rates were higher than the adult, right? Blood pressure is lower. So the normal systolic blood pressure of an adult is going to be anywhere between 90 and 120 millimeters of mercury. Okay, that's considered book normal, right? Textbook normal. A pediatric, the systolic, which is the top number of your blood pressure, it's going to be lower. Okay, so it might be closer to 80 or 85. The younger you get, an infant, maybe 70s, 70 up to 100, around there. And a neonate, firstborn, just came into the world kind of thing, I might be 60 to 80, which might be normal. Okay. So understanding what is, again, quote unquote, normal is important. And for your blood pressures, taking a look at table 10-7 will help you with that. So 10-6 for your heart rate, 10-4 for your respiratory rate, and 10-7 for your blood pressure. So make sure you take a look at those just so you can have that understanding of the differences between the adult and pediatric and where we are. Now your glucose levels, the normal glucose levels of a non-fasting adult, which means that, they're just eating and drinking like normal, right? Or they're not withholding that. They're not withholding food or drink. So a non-fasting adult, your normal glucose level will be 80 to 120 milligrams per deciliter, okay? For a neonate, we need to have at least 70, okay? So if it's lower than 70, then that's probably not so hot for those kiddos. But you guys will learn, again, in Mod 2, once we start talking about diabetic emergencies and things that are affected by glucose, just because they don't fit the textbook normal number doesn't mean that it's abnormal for that patient, okay? And this is really important to understand. The blood pressures, especially blood pressure, when you 120 over 80, right? That's like your quote unquote normal for an adult, 120 over 80. But let's say that you get a blood pressure on somebody and it's like 140 over 90. Are you going to flip out? Are you going to, freak out and be like, oh my gosh, this is high blood pressure? Well, your next question should always be to that person, what is normal for you, right? What's normal for you? Because I can guarantee you, if you're going to take my blood pressure, my systolic is probably going to be in the 130s. It might be in the 140s, depending upon what I'm doing. But that's normal for me, right? And I'm not experiencing any kind of abnormalities or any kind of symptoms or anything like that from a high blood pressure. So once you obtain your vitals, including glucose, if it's outside of what you know as normal by the textbook, then investigate it a little bit further, right? Talk to your patient. What is normal for you? And especially when we're talking about glucose, especially on our diabetic patients, you may have somebody who has, maybe their blood glucose is like 150 or something, which is a little on the higher side. But they say, yeah, that's about where I am right now. I'm working with my doctor to, to get that better. But that's normal for me, right? So again, get your vitals, think about the normal range, and then ask what's normal for your patient. The pulse ox, a normal pulse ox, is going to be 94 to 99% on room air, right? Remember room air, RA. So 94 to 99% is normal. I always want my pulse ox to be above 94. If it's less than 94, then they need oxygen. Okay, I'm just going to say that right now. If their pulse ox is less than 94%, they need oxygen. Okay, whether you give it to them by nasal cannula, non-rebreather, or if they're not breathing adequately, you deliver that oxygen with a BVM. Okay, so as long as it's above 94, it's good. All right. If you have a patient who's experiencing circulation issues from shock, which we'll go over shock in just a minute, then your tip of their finger, and if their blood isn't, they, and keep that in. Let's Hang on just a second. Okay, I think we're on. Gracious. So with you guys, cutting in and out. I'll still hear me now? Somebody? Okay, we're gonna try this again. Can you guys hear me now? Okay, good. All right. Fantastic. I don't know what happened. I know there's some guys working on roofs, on our next door, and I mean, I'm sure everything's fine, but all the lights are good on my internet, and I had my son get off Xbox. I don't know, maybe that was it. I don't know, but hopefully we won't have any more issues, and we will keep going. And just so you know, when I left the kitchen to go check the internet box in the living room, I caught the dog on the couch, and he looked at me like, "Aren't you supposed to be busy?" So anyway, thought that was kind of funny. Okay, so let's go back to our exam 1 review and keep going. Okay, so when I was talking about your pulse ox and how you have to have good circulation, right? You have to have good circulation in order to have an adequate or have an accurate, if you will, pulse ox, right? Because if you have that pulse ox on the end of your patient's finger and the blood is not circulating appropriately, then it's not going to be accurate, right? It may be giving me a reading that's actually not accurate. And if I'm basing my treatment on that reading, then I may not be managing my patient the right way. So when you have a patient who's in shock, which we're about to talk about, and they're not perfusing well, then just kind of keep that in mind. Your pulse ox may not be correct, and you may need to kind of base your treatment more on how your patient looks and how your patient feels versus that number. Okay. So let's go into shock. All right. Now there's a couple questions on here. We've got the early signs, the late signs, all the different kinds. What's the treatment and all that good stuff, right? So let's just talk about what shock is in the first place, because this is chapter 13 in your book, and it's a really big and important chapter. Because all the airway stuff that we've talked about and how we've put so much emphasis on all the airway, shock is equally important, because airway is all about respirations and ventilations, and making sure that we're getting oxygen into our system. But if the blood is not circulating in the way that it should, then that's also important, right? Or that's also something that we need to try and fix. So shock is another way of saying hypoperfusion. And perfusion is the circulation of blood, the delivery of oxygen to all of your tissues, and the removal of carbon dioxide as that waste product, right? The removal of carbon dioxide back to our lungs so we can get it out of our body. As long as all of that is working and oxygen is being delivered to all of my cells, then I have good perfusion. But if something is happening, and there's multiple things that can cause problems with this, but if something is happening and I'm not delivering oxygen to all of my tissues, then I have hypoperfusion or shock, okay? And when we were talking about respiratory progressing into respiratory failure, progressing into respiratory arrest, shock has its own progression, okay? So before we even get into number 8, we're going to talk about a couple things here, okay? And I'm going to pull up shock pump pipes fluid. Let me see. Let's see if I can pull this up. Nope, that is not a good picture. I'll get you something. Hang on. So an easy way to think about this is, in order to have good perfusion, you have to have adequate blood volume, adequate heart function, and your blood vessels need to be doing what they're supposed to be doing, right? They need to be constricting and dilating as needed in order to keep moving the blood around the body, right? And so when you have shock or hypoperfusion, one of 3 things, one or more of the 3 things is present, and that is inadequate blood volume, inadequate heart function, and inadequate vessel tone, okay? There we go. This is the easiest way for me to explain this to you. Okay, I know it says problem with simple terms, whatever. I'll talk about this in just a moment. But the simple term is the pump, the pipes, and the fluid. But if you think about the pump is the heart, right? This is like the engine, okay? The pipes, which is the distribution system of our blood, that's our blood vessels. And the tone, the vascular tone is important. Is your body able to constrict and dilate as needed to help with the distribution of the blood? And then the fluid levels in your body is the blood volume, okay? So if you can remember those, and if you have inadequate blood volume, inadequate heart function, or inadequate vessel tone, then you will have shock. Your patient is going to be in shock, okay? So, let me go back over here. Cardiac output. So do you remember when we were talking about minute volume? We were talking about our minute volume formula. for our respirations, right? Okay, we're talking about minute volume equals your tidal volume multiplied by your respiratory rate, right? Minute volume is how much air I bring in a minute. Your tidal volume is how much air I bring in per breath, and your respiratory rate is how many breaths per minute. So tidal volume times respiratory rate is going to equal my minute volume, right? If you guys can understand that concept, then you'll be able to understand your cardiac output formula, which is your respiratory, right? So your cardiac output, this is CO, this is cardiac output, is going to equal your heart rate, which is how many beats per minute, right, times the stroke volume. And the stroke volume is how much blood is pumped out of the heart per heartbeat, okay? And so if I multiply my heart rate times my stroke volume, that gives me my cardiac output. And when your patient is experiencing shock or hypoperfusion, they have decreased cardiac output. Okay, so they have decreased cardiac output. One of the things that will really help you kind of understand this is when we're talking about the phases of shock, the compensated shock versus decompensated shock. In the beginnings of you having a problem, maybe your patient is bleeding, or maybe they have an infection and they're starting to get septic. And we'll go over all of those in just a moment. But they have a problem that is affecting the circulation of blood, okay? And it's either causing inadequate blood volume, inadequate heart function, or inadequate vessel tone. One of those three, right? So we have a problem there. Your cardiac output is going to start to drop. And your body in the very beginning, your body is still able to adjust in order to maintain perfusion or maintain cardiac output. And the biggest thing is this heart rate right here goes up, okay? So your stroke volume, which is the amount of blood that's pumped out with each heartbeat, okay, this is going to start to drop, which drops my drops my cardiac output. In order to maintain this, if my stroke volume drops, then my heart rate has to go up, okay? So in compensated shock, your vitals that you will see is tachycardia and normal blood pressure, okay? So that tachycardia is what is maintaining that normal blood pressure. You can think of, if you want to kind of think of blood pressure as a representation of perfusion, it's a very basic concept, but if their blood pressure is low, then you can think of, well, their perfusion is low, right? If that kind of helps you with the understanding of this. So in compensated shock, right? So there is a problem, there's a problem going on, and something is affecting the way the blood is moving. In order to maintain perfusion, the heart rate goes up. So I'll have tachycardia and normal blood pressure. If that problem persists and doesn't get fixed, your heart rate, even though it has increased, it's not going to be enough to compensate for the problem. And so you're going to go into what's called decompensated shock. When your heart rate is still going to be up, it's actually going to be even higher, but unfortunately your blood pressure has now started to drop. Okay, so you're going to have developing hypotension. So when you're over here and you're looking at your review, the early signs of shock, which is our compensated, your early signs are going to be tachycardia and normal blood pressure. A late sign is tachycardia and low blood pressure or hypotension, okay? And that's kind of the defining moment of when we go from compensated shock to decompensated shock. The defining moment is when your blood pressure starts to drop. So think back when you guys were learning how to take vitals, right? And we're learning all about our blood pressures and what it means and all that kind of stuff. So you have two numbers that we get for our blood pressure, your systolic, which is the top number, and your diastolic, which is the bottom number. Your systolic, that is that's the pressure that's in your arteries that your left ventricle has to overcome in order to beat and contract and move blood forward. Okay. The diastolic is the pressure that's in the arteries when your heart is at rest. Okay. So you can think of the systolic is the pressure during contraction, and diastolic is the pressure during relaxation. Okay. If it's low, remember hypotension is low, then that means that the blood is just, it's not circulating very well, and you've got shock, hypoperfusion or shock. Okay. So the early signs of shock is what we call compensated. You'll have tachycardia, normal blood pressure. Your late sign, which is decompensated shock, you'll have tachycardia or even more tachycardia, and now low blood pressure or hypotension. Okay. So if you understand that piece, then it'll kind of help you a little bit with these next questions, these 4 categories of shock. Okay. So the different types of shock, or causes, if you will, you can kind of think of it this as not types, but causes of shock. Remember, you either have inadequate blood volume, inadequate heart function, or inadequate vessel tone. So this first category is called hypovolemic shock. Well, if you know your medical terminology, hypovolemic, that's low volume. So this one is an inadequate blood volume or inadequate volume. Your heart is okay. Your blood vessels are okay. The problem is the volume. Okay. And the different things that can occur in here, the first one and the most obvious is when you have bleeding, right? When your patient is losing blood volume from either external bleeding or internal bleeding, like if they were bleeding into their abdominal cavity or their pelvic cavity or something like that, right? The blood is not within their blood vessels, and so it's not there to circulate. Another cause of hypovolemic shock, because it's a volume problem, is going to be when someone is actually losing volume or losing fluids and they don't replenish it. So think about someone who's dehydrated, okay? And it's getting, it's summertime it's kicking in, right? It's starting to get hot outside, and that humidity is just making it worse. But the heat, when you're sweating and sweating and sweating, you're losing fluid from your body. And if you don't replenish that fluid by drinking water, then you could actually go into hypovolemic shock. I know this sounds crazy. You're like, well, how could I actually go into shock? My blood pressure is going to drop, and I'm going to, have super problems if I'm just outside sweating a lot. Because it does. Because you're losing volume and you're not replenishing it. Okay. Another cause of hypovolemic shock could be maybe someone who's been experiencing nausea, vomiting, and diarrhea for a certain amount of time, and they're not replenishing the fluids that they're losing. Because when you're vomiting and you're having diarrhea, you're losing fluid from your body, right? It's not blood, but it's fluid. It's volume. And if your patient is not drinking fluids, replenishing those fluids that they lose, then they can go into hypovolemic shock. Okay. The first stage of hypovolemic shock is your compensated shock, where you have tachycardia and normal blood pressure. The late stage is your decompensated shock, where you have tachycardia and now low or hypotension, low blood pressure, right? So all of these different types of shock will go through these same phases. Okay. These are just the certain causes of the shock. And once we figure out the cause, we know how to treat it, how to manage it. Your cardiogenic shock, this is a pump problem. This is a heart problem. Okay. You have inadequate heart function. You have good blood volume, and your blood vessels are good. You have good vessel tone, but your heart is not functioning appropriately. You have inadequate heart function. That's your cardiogenic shock. And the most common cause of cardiogenic shock is a heart attack, where the heart muscle itself is is damaged from lack of oxygen, and so therefore the heart is not pumping effectively. Okay? Heart failure is another form of cardiogenic shock. If your patient had myocarditis, and again, something that is making something where the actual heart itself, the heart muscle, because the heart is a muscle, right? The heart muscle isn't functioning appropriately. That is cardiogenic shock. Your main one, your most common one is the heart attack, your acute myocardial infarction, the heart attack, okay? And just like I said before with hypovolemic shock, you'll still see the early signs, and if it doesn't get fixed, you'll see the late signs. And once your patient starts developing hypotension, you're behind the 8 ball. You're late. Well, I don't want to say you're late, but you have more problems, okay? Because if they're not perfusing and that blood pressure drops, then now they're going to have altered mental status. They're not delivering oxygen to everything that they should be. That cardiac output has really dropped, and now I'm having a lot of problems, okay? And your patient might deteriorate into cardiac arrest. It could be from low volume. It could be from dehydration. It could be from nausea, vomiting. It could be from a heart attack. Okay. This next one is distributive shock. Distributive shock is a blood vessel problem. Okay. Do I still have everybody? Okay, cool. Burn. Yes, Josh, burn victim. Absolutely. You can have hypovolemic. Actually, we call it relative hypovolemia because they have the volume still in their body. It's just not in the right place, but they can still go into shock. Okay, so absolutely, and we'll talk more about that in Mod 3. But distributive shock is going to be your blood vessels, right? So out of those 3 that we talked about, your blood volume, your blood vessels, and your heart, the problem in distributive shock is your blood vessels. This is the distribution system of moving the blood throughout your body, okay? So your blood vessels have a problem. You have enough blood volume and your heart is working appropriately. It's just your vessels aren't moving it the way it should. Okay. And when you have distributive shock, there's three very distinctive problems or 3 very distinctive causes of distributive shock. And that's going to be neurogenic, sepsis, and anaphylaxis. Okay. So in distributive shock, when I say you have problems with your blood vessels, the problem is that you have this widespread systemic vasodilation of your blood vessels. And systemic means body-wide. So widespread systemic or body-wide dilation. Remember, dilation is when when that lumen gets larger, so it's opening up. So dilation of the small arterioles and small venules and just all of your blood vessels, okay? And so it's not moving the blood. Let's talk about sepsis first. So sepsis, the thing that we know about sepsis is that there's always a source of infection with sepsis, okay? Bacteria and stuff like that. So the bacteria from the infection is going to release toxins, and those toxins act upon the smooth muscle, which, on the outside of your blood vessels or the smooth muscle of your blood vessels, and that is what's going to lead to that vasodilation. It also leads to what we call increased capillary permeability, and that's just a really fancy way of saying there's going to be a little bit of leaking of fluid out of your blood vessels, okay? The problem's not the leaking, the problem is the vasodilation. So sepsis, some kind of source of infection, and that can be pneumonia, that could be a UTI, a urinary tract infection, an upper respiratory infection. Okay, it could be a spider bite that got infected or a mosquito bite that got infected. Anything, okay, to where the bacteria is now wreaking havoc within the body, basically. And the toxins cause the systemic vasodilation. In septic shock, the very earliest phase, your patient's going to have tachycardia, normal blood pressure, right? And if it continues, so like if the patient isn't treated with antibiotics, and things like that, because the antibiotics is what treats the cause of the shock, if they don't receive that, if they don't go to the hospital and receive that treatment, then it's going to continue to get worse, and it's going to be high more problems. It can lead to organ failure and all kinds of things, right? And cardiac arrest. Another form of distributive shock is anaphylaxis. And you guys are going to learn in Mod 2 how we can fix anaphylaxis as an EMT. Okay? So anaphylaxis, that's when we have the, we get exposed to an allergen or some kind of substance that our body does not like. But it's not just a regular allergic reaction. Anaphylaxis is kind of like that allergic reaction on steroids, right? That's like, it's the big one, right? We have this uncontrolled histamine release that occurs in the body. And that uncontrolled histamine release is what causes the widespread systemic vascular dilation and other issues. It also causes bronchoconstriction, which is why they have breathing problems. Okay, it can cause that. Oh my gosh, swelling in the throat, in and around the airway, right where you hear your stridor. We're going to talk more about anaphylaxis and allergic reactions in Mod 2, but the big one is that vasodilation. Okay. Do you remember at the beginning of this review when I was talking about the sympathetic versus parasympathetic nervous system? And sympathetic nervous system, the hormone that releases is epinephrine. And one of the things that epinephrine causes in the body is vasoconstriction. So we treat anaphylaxis with epinephrine. Anaphylaxis is a form of distributive shock that causes vasodilation. So when I give the epi is going to cause constriction and combat the effects of that histamine. Okay. So just make sure you know sepsis and anaphylaxis are your distributive shock. Another one is neurogenic. And neurogenic is kind of unique from all the other causes of shock because it's kind of based upon the location. Neurogenic shock is a spinal cord injury. And when that spinal cord injury occurs, if you can, let's see here. Spinal cord. Right. So let's say there's a spinal cord injury right here. Okay. This is about my thoracic. Okay. Because I've got my cervical. Here's my thoracic. Here's my lumbar. Let's say you have a spinal cord injury right here. In neurogenic shock, if the injury is to the point where it disrupts the communication from the nerves, from your peripheral nervous system, then everything inferior to that injury point, everything inferior, all of your blood vessels will vasodilate. Everything superior to it will be okay, though. And so that's the key difference between sepsis and anaphylaxis and neurogenic. Sepsis and anaphylaxis is a systemic, body-wide. It affects the whole thing, right? The toxins from the bacteria in sepsis affects the whole thing. It can't say it's just going to affect this part of the body or not. Anaphylaxis affects the whole body, but neurogenic is based upon that spinal cord injury, the location of that spinal cord injury, okay? And anything inferior to it will be vasodilated versus anything above or superior will still be working normally. Those blood vessels will still be functioning normally. So that's the difference between neurogenic and those other ones, okay? Let's see here. Let's go back. Obstructive shock is our last category of shock, if you will. Obstructive shock is there's an obstruction of blood flow, okay? There's not a volume problem. There's not a heart problem. The heart is still okay. The muscle is still okay. You might have something that's keeping the heart from doing what it's supposed to do, right? It's obstructing the normal blood flow, or you might have an obstruction of blood flow, okay? So some kind of condition exists that obstructs the forward blood movement, The three big ones that we talk about are tension pneumothorax, cardiac tamponade, and pulmonary embolism. Those are the three big causes or types of obstructive shock. So let's talk about tension pneumo first. And we're going to go into tension pneumo a lot more when we discuss Mod 3 with trauma. But if you have a really good understanding of what a tension pneumo is right now, then it's definitely going to help you when we get to our trauma, okay? So a tension pneumothorax is something that progresses from a pneumothorax, okay? You can think of pneumothorax, that word means collapsed lung. You can have an open pneumothorax, and that's where if there's like a puncture in the chest and it's open to the outside environment. You can have a closed pneumothorax, and that's where the chest, and remember this could be anterior or posterior, but the chest, there is no hole in the chest. Okay, maybe it was blunt trauma and a broken rib punctured the lung, right? So it's closed to the outside environment, but we're still having issues. And then you can have a spontaneous pneumothorax, which is normally somebody was hacking and coughing and it actually popped a lung. Okay, now you don't need to know all that stuff right now, but I want you to understand that a tension pneumothorax doesn't just happen, it progresses. Okay, so you can have either the open, the closed, or the spontaneous. One of those things happens and your lung is damaged. And you have this lining. This is called the pleural lining or the pleural membrane, okay? It's the it's the inner lining of the thoracic cavity. That's the pleural membrane. The membrane that's on the surface of the lung, that's called the visceral membrane. The space in between is called the pleural space, okay? And this one, you see how this is okay. I've got the pleural membrane that's around the cavity, and then I've got the membrane that actually lays upon the lung, okay? Which is the visceral. So let's say that this lung gets injured somehow, whether it's a broken rib, whether it's a stabbing, it's something like that, right? And we start to have air escape, and the air starts to escape into this pleural space, right? It starts like this, and it starts to escape into this pleural space. And as that accumulation of air continues, it's going to completely collapse this lung. And if it keeps going to where I have a lot of air accumulation here, it's going to take this mediastinum, which is where the heart is. This is where the heart is, okay? And it's going to push it. It's going to compress it and push it to the side. It's going to push it to the other side, okay? Here we go. You can't really read all of these, but you can see the picture. Okay, so we can see the accumulation of air in the pleural space collapses the lung, and it's now pushing the opposite lung, the other lung that's not affected, and here's the heart in the middle, right? The heart normally is in the middle. This is shifted position over. So if you have a heart that is being compressed, now the heart muscle is okay. Remember, this isn't cardiogenic shock. This is obstructive shock, because the heart is okay, but something is compressing it. Something is keeping it from being able to expand and fill with blood and then contract like it should, okay? It still doesn't show the heart, but anyway, the heart's in here and it's been pushed over to the side, right? Remember Starling's law when we talked about it at the very beginning on literally the first question. And I talked about that rubber band, right? If I stretch that rubber band in both directions by 2 inches, then I should, it's gonna come back 2 inches, right? So you can think of the heart, the stretching of the rubber band is the heart filling, and the rubber band coming back to its normal position is the contraction when the heart pumps the blood out. Kind of think of it that way. If this heart is being compressed because of all this air accumulating in this pleural space, and it's pushing on, pushing on the heart, then it's not going to be able to expand very much, right? And it's not going to be able to fill with a lot of blood. So the volume, the stroke volume of the heart is going to decrease. And if you remember your cardiac output formula, cardiac output equals the heart rate times the stroke volume. The stroke volume is decreased, so it affects your cardiac output. And now we have shock, obstructive shock. Your first phase of this is compensated because that heart rate's going to increase and keep that output going. As this continues and gets worse and worse and worse, and it compresses the heart even more, and we have less volume, your blood pressure is going to drop. Okay, so that's a tension pneumo. A tension pneumo is where the air accumulates. Okay, it has to start somehow as either an open, closed, or simple. Right? You see how this is actually kind of cool. I'll probably use this for your trauma. Closed, the chest wall is intact. Open, there's a hole. But either way, I'm starting to accumulate air in that pleural. It's into a tension pneumo and everything. Cardiac tamponade. Oh gosh. Okay. All right. Okay, so hopefully this works, is good now. I think we're good now. Thank you so much. I truly apologize. This is really frustrating. I'm sure it's frustrating for you, but it's very frustrating to me. I'm sorry. This never happens. So we talked about tension pneumo. Now let's talk about your cardiac tamponade. Okay, and your cardiac tamponade again is your form of obstructive shock, or another form of obstructive shock. So let's look at cardiac tamponade. Is going to be another thing that we discuss pretty in depth when we go into mod. But again, just understanding. Let's do this one. So cardiac tamponade, or another word for this is pericardial tamponade. They're interchangeable. Okay. You have your cardial sac, which is around the heart. Or blood or any kind of fluid that builds up or starts to fill this sac around the heart, then yet again, your heart, although it's okay, the muscle is okay, it's being compressed and it cannot fill with, if it can't fill with blood, it can't contract, your stroke volume decreases and your cardiac output decreases, okay? And you're gonna start to see your patient in shock. And we'll talk more in Mod 3 about other signs and symptoms, Beck's triad and things like that, other things to see. And then last but not least, we talk about your pulmonary embolism. Pulmonary embolism, your next, or your last, if you will, example of obstruction. Okay. Let's get a good picture here. Okay. So blood clot that formed somewhere else in the body, most get trapped by the vena cava. If it's in the lower extremity, then this is the inferior vena cava is bringing it up, right? It comes into the heart, it gets pumped through the right atrium, the right ventricle, into the lungs, into that pulmonary artery, and that's where it lodges itself. Okay, it lodges itself in that pulmonary artery, in your pulmonary circulation, and it blocks the blood flow of blood back to the heart for your heart to pump it out. Okay. Pulmonary embolism can be a very critical patient, and these patients are hard to manage sometimes, depending upon the size of the embolism, the location of the embolism, and of course, how much blood is it actually blocking, right? But it's going to inhibit the return of blood flow to the heart, right? Because it comes in here and it hits your alveoli and it gets, the gas exchange and all that kind of stuff. And then it comes back to the heart by the pulmonary vein. So it can go through the left side and get pumped out with the left ventricle, right? But if there's a blockage, then that means I'm not going to get all of my blood volume back to the heart. And if I don't have all my blood volume, my stroke volume decreases, and my stroke volume decreases, my cardiac output will decrease. So obstructive shock is an obstruction of the blood flow from tension pneumo, cardiac tamponade, or pulmonary embolism. Okay. Okay. All right. Okay, so we're still here. Perfect. What's the shock? Well, if I can recognize it early, and I can figure out the type of shock that we have, then I might be able to address it. And right, just figuring out the type of shock, that has to deal with all of this stuff right here we're talking about, right? Is it, are they losing blood? Is this external bleeding? Will I have to stop the bleed, right? Put direct pressure, maybe put a tourniquet, right? I can stop the loss of blood, or I can stop that volume issue with that, right? Cardiogenic, if it's a heart attack, I can't stop it, but I might be able to help reperfuse a little bit with some of the medications that we'll learn in Mod 2, okay? Tension pneumothorax and cardiac tamponade and pulmonary embolism, as an EMT basic, you can't fix those, but we can recognize it and get them to the appropriate trauma facility. And then distributive shock, with our sepsis, our anaphylaxis, our neurogenic. Anaphylaxis is really the only one that we can treat per se with medications as an EMT. Sepsis, though, I can recognize that infection, right? And remember, when someone has an infection, they most likely have a fever, right? A fever. Just remember that. But the treatment of shock is recognizing it early. So you get on scene of a call, you have a patient that has a complaint, you're talking to them, you've done your primary assessment, maybe they don't have any life threats, right? Their airway breathing is okay, they've got decent pulses, blood pressure seems to be okay, that kind of thing. You get in there and you're starting to get your secondary assessment and you obtain your vital signs. And you have a tachycardic patient with normal blood pressure. So that tachycardia, that higher than normal heart rate is from something, and you need to pay attention to that and investigate it, okay? If you get there and they look sick and maybe their skin is pale and they're going to have patients in shock will be cool and clammy, okay? They're cool and clammy because the blood flow is not getting out to all of their peripheries, right? And, they don't have that good blood flow, so they're not going to feel warm. Their skin is actually going to feel cool. The only one that is not going to be cool is your neurogenic, because your neurogenic shock, remember, is very different from the others. It's based upon the location of the spinal cord injury. Your neurogenic shock is going to have warm and dry skin versus everything else, whether it's sepsis, anaphylaxis, hypovolemia, a heart attack, they're going to be cool and clammy. So colder or cool skin and that diaphoretic clamminess, okay? So if you walk in and your patient is sick, they've got that, the skin is off, they're tachycardic and hypotensive, then you're already, into this shock, right? This patient is already into the shock, and I have to act now. I got to get him. I got to figure out what the cause is. Can I fix it? Can I stop it? Can I help it? Can I manage it while I get them to the hospital where that definitive treatment will occur, right? So recognize it early. That's the big piece. And we recognize it from our vitals. Are they in compensated shock or decompensated shock? Figure out the type. Can you treat it? If it's anaphylaxis, we give them epi, right? If they're bleeding, we stop the bleed. Things like that. You also want to keep your patient warm. So keep them warm. Put a blanket on them, right? Keep them warm. Treat their ABCs, give them oxygen. Because if they're not perfusing, then that means that they are not, the blood's not circulating and the oxygen isn't getting into all the places it needs to be. I want to go ahead and get them on a high flow O2, maybe a non-rebreather. So whatever blood is circulating is as maxed out with oxygen as possible, right? So keep them warm, give them some oxygen, and transport them to the hospital, We'll talk a little bit later about positioning. There's some new studies about what's called the Trendelenburg position. Trendelenburg is where we raise their lower extremities. We put them in a supine position and raise their legs, so their blood volume kind of stays in their core, if you will. That's not necessarily an absolute treatment of shock, but keep them warm, manage your ABCs, give them oxygen. If you can recognize the cause and treat the cause of the shock, then do it, and then rapid transport. Okay. Orthostatic vital signs. This is interesting. Orthostatic vital signs are, I'm going to get these vital signs if I feel like a patient has a fluid problem or a volume problem, right? They're not sufficient with their volume. I will gain or obtain a set of vitals with my patient in the supine position and in the standing position. Now you can do it supine, sitting, and then standing, and just see what your changes are. But you'll definitely see changes if they are low in blood volume or volume, not just blood volume, but volume. Then you'll see a difference in the vitals you obtain when they're supine versus the vitals you obtain when they're standing up. And these are called orthostatic vital signs, right? When your patient is low on blood volume, I keep saying blood volume, but is low on volume or fluid, right? I don't want you to think it's only blood, because remember, volume problems could be from dehydration and vomiting and diarrhea and things like that too. But when you have this, I want you to think of this is supine versus this is standing, right? Their blood gets the volume, it gets redistributed when we change their positions, okay? And if they're low in volume, then, and they're standing up, then that means their heart has to pump a little bit more or a little bit harder against gravity to get it up to the brain. Okay, and if you have volume problems, then it's going to reflect in your vitals. Okay, so if you have a patient who anyway, if you have a patient who's not feeling good and maybe they get dizzy when they stand up, or you know their blood pressure is low, or just something like that, right? Maybe they just don't feel good and they feel worse when they're in more of an upright position. Then if you can, try and get some orthostatic vital signs. What we call a positive tilt test or a positive finding of orthostatic vital signs is when you go from supine to standing. When they're standing, if they have a drop in at least 20 points of their blood pressure, or if they have an increase in heart rate by 20 to 30 points at a minimum, then your patient is positive for that tilt test, and that means that they have low volume. Okay. Sometimes you don't even have to get those vitals though, okay? And I'm gonna tell on myself here. When I was a brand new paramedic, I was trying to do a tilt test on somebody, and this guy, when I had him standing up, he was like, "Man, I am lightheaded. I'm dizzy. I need to sit down." And I was like, "We're almost there, you know?" And that guy almost passed out because I was gung-ho. I was gonna get this blood pressure, right? But just the mere fact that when he went from laying down to standing, he was lightheaded and dizzy, and he felt his heart beating faster, and he was sweating. All of that stuff right there, which I was learning, but all of that stuff right there are positive signs of a tilt test. But your orthostatic vital signs is when you get vital signs when your patient is in supine versus standing, and if they change and suggest low volume, then they're positive for that. Okay. So we all got to learn some way, right? Okay, so that's the last one on this, but if y'all know anything about me, I go into more. So I'm going to talk about a couple more things just to make sure we are good with it. Okay. So like I said before, make sure that, your A and P, we really haven't discussed the different organs that are in all the different abdominal quadrants, right? You have your right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Abdominal organs by quadrant, right? So make sure you know, first off, that your stomach is divided into 4 quadrants, and then what is in each. Okay, A and P, super important, right? And then another part of this is what is considered a solid organ and what is considered a hollow organ. A solid organ, oh, wait, which one? Where was that picture I liked? Anyway, a solid organ, here it is going to be anything that is full of tissue, okay? Anything that's solid tissue. It doesn't have a cavity that's filled by something else. For example, your stomach is not a solid organ. Your stomach is a hollow organ because it gets filled with food, right? Your bladder is a hollow organ because it gets filled with urine. Your intestines, those are all hollow. But like your spleen and your liver, those are solid organs because they don't get filled with anything else. It's just solid tissue, right? And those solid organs, because it's just tissue throughout, it's very vascular. So there's a lot of blood. And if there's issues and problems, ruptures or penetrating injuries or any kind of damage to that solid organ, then I'm worried about blood loss, right? If there's damage to that hollow organ, like my stomach or my bladder or other hollow organs, then I'm worried not only about some blood loss, but I'm worried about the contents of that organ now spilling into whatever cavity I have and causing problems, infection, and things like that, okay? But it's also very important, like we said before, to know what is in each quadrant. And that's going to help you, especially when we get into Mod 2 and we start learning about all the different stuff. When you have a person who says, man, my stomach hurts right here, and they point, and you're going, man, I wish I would have looked at my A&P because I don't remember what is in that quadrant, right? So make sure you know your A&P as far as that's concerned. Your brain and your spinal cord, right? What are the different parts of the brain? What do they do, right? What does the cerebrum do? What does the cerebellum do? What does the brainstem do, right? We have different parts. Your vertebral column, right? Your vertebrae. You have, right, cervical, thoracic, lumbar. 1, 2, 3. We got 5 different parts of it, right? So what are they? What's the order? How many vertebrae do I have in each section? Okay, so just kind of knowing that kind of stuff, okay? Remembering, again, that the body breathes because of the buildup of CO2, not the need for oxygen. I mean, we need oxygen, yes, but the fact that our breathing rate is controlled by the levels of CO2 in the body is important to remember, right? And it's all about that medulla oblongata in your brainstem, okay? Those baroreceptors, it's good to know where all that stuff is, right? Make sure that you understand the concept of the minute volume formula that we talked about last class, right? Minute volume formula. Okay, so make sure you understand what all that means. Okay, minute volume, right? And you understand what is the tidal volume. The tidal volume is the amount of air that we move per breath. Minute amount of air that's moved per minute, because we've got the breathing rate and the volume, right? Understand that cardiac output formula that we talked about when we're discussing shock. Because if you can understand that, then you can really understand shock. If something is causing the stroke volume to be low, whether it's low blood volume, the heart's not pumping appropriately, the blood vessels aren't bringing blood back to my heart, so I don't have enough preload, and so my volume isn't good, or the rubber band, right? The rubber band theory isn't working very well because it's being compressed and my volume is low, so my volume is low. It's going to lower my output, and so my heart rate, in order to make this still work, my heart rate will go up. So if you can understand that, then you'll have a pretty decent understanding of your shock. What's your normal vital signs, so that way when you do obtain those vital signs from your patient, you can understand, is there a problem, right? One of the things that I learned very early on in my career, and if you've heard me say this before, my apologies, but hypotension is never normal. Low blood pressure is never normal in somebody. Okay, it's always an indication that there's an issue somewhere. Hypertension might be a normal for someone, right? I'm not saying I want you to just, if you get, a high blood pressure like 180 over 120, whatever, that's probably normal. Don't discount it, but it might be their normal. Hypotension should never be normal. So take a look when you have hypotension, okay? Make sure you know your BLS. You got to know your BLS, okay? Because when we get on scene of that call and your patient is unconscious, unresponsive, and they don't have pulses, you have to know what to do. And you have to know how to do it appropriately. How does the AED work? When you have help, are you doing 30 to 2? Are you doing 15 to 2? Are you, think about what we talked about with that kiddo who has a pulse, that pediatric that has a pulse, but it's less than 60 a minute. Remember, you have to ventilate first and then do compressions if your ventilations don't help that heart rate, right? Airway management. When we're going over that BVM ventilation of the apneic patient, in some classes we were able to go over it last week or last class. Some classes we'll go over it next class before your before your exam. But that skill is to go over, how do I manage a patient's airway when they are apneic? And apneic, remember, means they're not breathing. So how do I manage that airway? Well, the first thing I have to do, because you might be asked a question that says, what do you do first? The first thing is I have to open the airway, right? And I'm going to open the airway with a head tilt chin lift on my medical patients, or a jaw thrust on my patients from trauma mechanisms that I suspect cervical issues. But open that airway. And then if they have any kind of gurgling respirations or noisy respirations, if it's gurgling respirations, then you need to suction that airway, okay? Because there's something in the airway and it's not patent. Then don't forget your airway adjuncts, your OPA and your NPA. Got to put those in. And then you ventilate your patient, right? So knowing the processes and the step-by-step of what problem are you presented with and how do I manage it to get to where I want to go with this, that's the most important piece of all of this. Okay, that is truly the most important piece of EMS, right? I want to make this person better. How do I get there? How do I get there appropriately? How do I manage what's presenting to me, right? Your patient assessment. Just remember that your primary assessment is the most important piece as far as your patient comes, right? Scene size up is always first, and we do that for the safety of the providers, not the safety of the patient, but the safety of the provider, right? And then making sure we get our resources to us. How many patients do we have? Do we get enough resources or the specific resources that we need? We're looking at the mechanism and all that kind of stuff. And then we progress into our hands-on looking at our patient. Primary assessment comes first with my ABCs, life threats, right? Then I go into my questioning and my vitals and all my other stuff. So, you guys, if you've done your chapters and you've done your emergency chart, then I think you'll be pretty good with this, okay? And as far as where your emergency chart is, because someone was asking me that on an email, I'll just make sure that you guys know where the emergency chart is. It's in your module. You can find, if you don't know where something is, and you're like, I don't know what module it's in, you can always come down here and go to your assignments in Canvas, right? Go to your assignments and then just go to the search bar and type in yellow emergency chart. I said this, it should be in your assignments. I don't know why it's not there. That's fantastic. Okay. Let's go to your modules. Open mouth, insert foot, right? There we go. Okay. Module 1. Scroll down. Oh, it's because it doesn't say yellow emergency, it's emergency charts. So there it is, right there, emergency charts. Okay, let me see if I can find it in here by just typing in emergency charts. Or even if I just said yellow, there it is. All right, so yellow emergency charts. When I select this, it's gonna take me to this, or it's gonna have me do this Google link, right? So it's gonna come over here to this Google Drive, and you need to fill in the patho behind what's going on with this, the signs and symptoms of what this is, how do I treat it, and what are some causes. And like we said before, you can use multiple resources. It doesn't have to be only your book. Your book is probably one of your best resources because it gives you the treatment that we would do as an EMT, right? The signs and stuff that you would see in the treatment as an EMT. If you wanted to go into more, though, you can absolutely use resources on the internet. That's totally fine. But I don't want you to lose sight of your treatment as an EMT, okay? Because, pulmonary embolism, they're going to be given, fibrinolytics and going in for surgery and doing all this stuff. And we don't do that as an EMT, So what's the treatment for that? But you will need to download this document to your own device, fill it in on your own, and then go back to your Canvas and submit the completed document. Okay, so just submit it as a file to your emergency charts. Okay, so if I viewed it as you guys, I would come in here, download it from the Google Doc, hit start assignment, and then upload my file here. And then save it. Always make sure to hit submit. Okay. Let's see here. Yeah, go ahead. So BLS, patient assessment, A&P, shock, airway management. Yep, there you go. So you guys know where to find me if you have any questions. We will be taking our exam at the end of next class, so the last hour of next class. So we will have some more review and stuff that we'll be doing before we do that. And again, make sure that you have your full uniform for next class on your person, right? Because we're going to be taking pictures. And just take a deep breath. All right, just take a deep breath. This is your first, your first exam. It'll be 50 questions. I'll give you an hour to do it, and we'll go from there. All right. So if you have any questions, you know where to find me. And medical legal, I don't really think there's any questions of medical legal on there. It's more towards the end, but it's good to have the knowledge of medical legal. I don't think there's any questions on there. Matter of fact, I'm pretty sure there isn't, but I will double check. But I'm pretty sure there isn't. So, but go ahead and, like I said, reach out to me if you have any questions, and I will see you guys on your next class. The emergency chart, this yellow emergency chart will not, the actual content on how we treat all this stuff is not necessarily on this exam, but it helps you understand the respiratory. We have, honestly, yellow, orange, red, and green. You have 4 emergency charts that go with your module 2. So that's why we have you start it kind of early with these respiratory emergencies that go along with airway. But I'm not going to be asking you how do I treat asthma? I'm not asking you that yet, right? We're not talking about what COPD is yet, but we need to get this done. Okay. You can review it at a later time, but get it done now. Okay. All right. I will see you guys next class. If you have any questions, reach out. Okay. This is going to be recorded for a week or available to you for a week. All right. We'll talk to you guys later.